Hello, can you hear me?
Yeah, thank you. Yes, very clear. Thank you so much.
All right. Please admit everyone who are in the waiting area. This is for everyone. So this is the last minute advice before your exam, which is likely next week. It will be a small session, and then if there is any question answers, then uh, you can ask. We will start our session. Um, Remember when you enter the exam room for this exam. This exam is a DGH consultant level exam, but this ask you something extra as well. In DGHS, we do not um, manage hemophilias and von Willebrand disease, but they expect you to know these things for the exam as well. On the RCPath website, this says that this is a DGH consultant hematologist level exam, but it is actually more than that. What happened on the exam day? You have this is a 3 days exam. First 2 days you will have a written exam, and then on the third day you will have a viva exam. If you have appeared in exam before, you will know that if you are going for the exam for the first time. So this is the pattern of exam. First 2 days you have written exams, and then on the third day you have viva. First day is for morphology, second day is for hemostasis and then transfusion paper, and third day is for the viva. You need to pass all of them. Then you will be considered as pass candidate. Before you travel to your exam center, I assume that all of you would know about your exam center now. Just confirm it again on the background of recent events with the part one exam. Um, uh, Make a list of the things that you need to take with yourself to the exam and exam center. This is your ID. They will check your ID that you have used to register for the exam. Make sure you have your own pen. The invigilators don't have much fun to give it to you. So you should have enough pen with you. Make sure your microscope is working, and this is the microscope that you have used for practice. It is a bad idea if you have used your microscope in home and then for the exam purpose you have taken your hospital microscope because things looks different in different microscope. If your eyes are used to a microscope that you were using for many months, better to take that microscope to the exam center. And I'm sure you all of you will have your microscope, and if it is from hospital, they would have given you few weeks before the actual exam. Microscope oil, um, it is not a costly oil. You can buy your own oil. Um, it's considered a bad if you ask for oil in the exam from someone else because there's a very tense situation during the exam and you cannot ask for oil from other person. Testing slide is must. Testing slide can be any slide from your hospital. It can be a NICPA slide or anyone's slide that you can take from your hospital and see on the exam day because you will go to your exam center for the morphology at 9. You need to set up microscope in 2 hours, and then usually it starts at 11 a.m. the first paper. You should have your own microscope oil and slide to see your microscope is functional. Tissues to clean the microscope, and watch is must. Okay. I made a mistake by not taking watch to the morphology because we have only one wall clock and the sun light was on the wall clock, and I had to beg for another watch to be kept uh, in the middle of the rows. So they were kind enough; they brought another watch, another wall clock, and they kept it on the chair in the middle of the two rows of the candidates. If you have an extension wire, better, so that you can place your microscope on the table at a position that you would like. Ideally, their extension wire is just generally 1 meter, and then two exam candidates are attached to one extension wire. If you have your own extension board, you can manage your microscope anywhere because they have a small table. You may be used to keep your microscope on your right side, on your left side. There, it will be only to one side, which may not be your actual side or routine side that you do in your routine working. So I had my own extension wire, and it was big enough. I could keep microscope on this side, on the other side of the table, wherever I was easy. Check your emails regularly. When the people travel for the exam centers, they usually do not check their email. Things can happen, events can happen just before the exam as well. So keep an eye on your emails for any change of exam center, like it happened in the recent past as well, and things like that. So keep an eye on your emails from RCPath. Day one morphology, 10 short cases, then a break, then three long cases. The problem is in the short cases because this is the first paper of the day. People have high level of anxiety, and people make mess in short cases, not in long cases because you had a break and the time is quite long for each question in the long cases. Um, People usually pass long cases easily, but the problem happens in the short cases where you have 9 minutes for each slide. In my exam center, they gave us 5 slides for 45 minutes. Then there was a 5 minute break. They says we will change over the slides. And they took the slide from us and give it to another person and took their 5 slides and give it to us. So my first slide was from 6 to 10, and then I had to do one to um, 1 to 5. In some exam centers, they may give you 10 slides and a whole, but this is what happened in my exam center. They gave me 5 slides first for 45 minutes, and there was a 5 minute break for changeover. They took the slides from us, gave, gave them to the other candidates, and the other candidates' slides came to me. Remember, you need to write your candidate number and the and the question number on each paper. This is must because when the exam is done, these sheets and papers they are separated from one another and distributed among the examiners. So once they are distributed in the examiner, each examiner or two examiner check your paper and then they are accumulated again. So if you have not written candidate number or question number, there is a chance that it will be lost. It may affect your exam. Always start your answer from a new page. If you are on case number one, um, write it on a page. But if you finish the case number one and now moving to case number two, it should be on a separate page or a separate sheet. If you can see this, this is a bunch of paper. Now, this single page is for one case, right? This is for one case only. If you have to start your answer for case number two, short case number two, you have to skip this page and start it from here. Okay. You may have enough space on sheet number one, but ignore that. As I mentioned, when these answers are checked, this paper will be separated and it will be given to an examiner and they will check your case number one. If you have written case number two on the same paper as well, it will not be marked. Okay. I assume um, your senior people in your hospital or your consultant would have told you this thing. So many people during the mock exam, they attempted the same cases, 2 cases or 3 cases on the same paper. Okay, but I have mentioned to them, do not do this in actual exam. Okay. So in actual exam, they have a lot of paper. Um, each short question should be on one sheet. If you have finished, turn the page, go to another sheet. Okay. And these sheets are separated, and there are 10 examiners. Each examiner receive their own case to be checked by them. If you have used two booklets mentioned on the front of the page, see other booklet. Less chance that they will miss your booklet, but still anything can happen um, in this exam. You need to attempt all the question. Okay, so 9 minutes for one short case. If you don't know the answer, you are confused, leave it, move to the next slide, and forget that case if you don't know the diagnosis, if you don't know the answer. It should not affect your coming slides. Okay, so that's why watch is important. Give 9 minutes to each short case. If that short case is taking more time, leave it. Move to the another short case. You need to complete your 10 cases in 90 minutes. They may have given you some hints in the history, like a patient with a trouble, and there is eosinophilia. So you may be thinking about parasite. They may have given you a patient, a young patient with epistaxis. Okay. Epistaxis in young patient, the exam scenario is APML. Okay. They may have given you that the patient has traveled to Japan or Jamaica, and now the counts are high, ATLN, or the patient has polyuria. You may be thinking about ATLN. So they may have given you some hints like that in the morphology. That is good thing that you need to pick it up. You have enough practice of morphology cases now. You will be able to pick them up. Better to better to write the answer in bullet points, not stories. If you will write your stories and they are irrelevant, you will have negative marking in the exam. They in my exam they have not mentioned negative marking. That was in spring 2023. Um, sorry, spring 2024. They did not mention anything about negative marking. But from autumn 2024, they have mentioned on the on the paper that if you write irrelevant things, there will be negative marking. The candidate can confirm who had appeared in exam recently. Blunders are risky. Remember, this is part two exam. Um, there is very little room for blunders and big mistakes because this is an exit exam and you will be consultants. If you make these blunders in real life, you are risking your patient life. They will not be expecting mistakes or blunders just like you did in part one exam. In part one, you were registrar, you were supervised by your consultants. But after part two, you'll be consultant and you'll be working independently. So better not to write CLL for Burkett and Burkett for CLL. This is a huge blunder and mistake. A single line can affect your whole exam because these exam outcomes are discussed in their meeting and they decide which candidate is safe to be passed and which candidate is not safe to be passed. Common questions in the morphology report, the blood thin, what investigation you would like to do next, what are the expected cytogenetics, flow cytometry, what are the differential diagnoses, likely diagnosis. These are the common questions that are asked both in short cases and long cases, and you have done the practice for these exams and for these questions. If there is anyone in the waiting area, please allow them. Then for the long cases, this is the relaxed part of the exam because you have three long cases with more than one slide or graphs, and you have enough time to think about your answer and write them. So it's less likely that somebody will fail the long cases. It's the short cases on day one that makes the big problem. So the questions are the same. They will ask you about reporting the blood thin, investigations, cytogenetics, etc. but they may give you HPLCs as well. HPLC can come in short case as well. We had HPLC in a short case. They can give you HPLC, electrophoresis graph, karyotype, fish, or Doppler even. We had a middle cerebral artery Doppler graph in our long case, and they asked us to interpret it. What you would do next? This is the middle cerebral artery Doppler of the patient. Patient has sickle cell disease, and the value was 200. What you would do next? Recently, they have started asking you about management in long cases as well, and about counseling. Like we had a case of APML, and they asked us to discuss the prognosis of the disease with the patient, or discuss the side effect related to the management of APML with the patient. So remember, the management, counseling, prognosis questions can be asked in the long cases as well. Again, if you write irrelevant things, they will not cross it. They will give you negative marks on that. This is an example of the morphology short cases. This is a candidate who has seen the blood film of APML, and he has written a report. The blood film is of APML. There are bilobe cells. Please conduct hematology urgently for further advice. The platelets are low and red cells look okay as well. And then there was another candidate who write the blood film like that. The blood film shows multiple bilobe and granular promyelocytes. There is a general thrombocytopenia and red cells are normally in count. Impression is most probable APML, which is heme emergency. Patient needs urgent review by heme and sending this sample to HMDS or PML Aurora stain. ETRA need to be started urgently in this case. What do you think? Which report is better in this case? The first one or the second one?
Second.
Yeah, the second one looks better because you cannot make any diagnosis on a blood film. Yes, these are bilobe cells, but you cannot say that this film is of APML. How do you know this is APML? We always say this is most probable APML. Your confirmatory test will only be if you have PML RARA stain, or if you have FISH, or if you have done bone marrow for karyotyping. Then you can say that this is confirmed APML.
Amir, you're muted.
Am I okay? Audible now?
Yep.
Yeah. So I was saying that you cannot make a diagnosis on the blood film. It can give you a high suspicion that this is APML, this is acute leukemia or myeloid leukemia or lymphoblastic leukemia, lymphoma, etc. But you cannot say that this blood film is of APML. You need further testing, which is staining, FISH, or karyotyping on bone marrow. So always say this blood film is most likely of APML, which would need confirmation on further investigations like PML RARA stain. We have HMDS in our hospital, and we take the sample over there and give us the results within 1 hour. If you don't have, then write the test that you usually do in such cases in your hospital. And then I was saying that don't say that please conduct hematology urgently for further advice. You are the hematology registrar or consultant. You have to write your suggestion or advice here. And if you think this is hematological emergency, this blood film can be of APML, can be of PTP, etc. You have to mention that this is hematological emergency, so that the examiner knows that you have picked that up, that this is hematological emergency, which would need urgent intervention in the form of ETRA, in the form of discussion with TTP consultant, etc. Okay? Always mention your impression. When you are reporting the blood film, you comment on 3 cell lines. Yes, white cell, red cells, platelets. So what have you made it up from this? If I'm a medical registrar and you have only mentioned red cell description, white cell description, platelet description, I will call you again, doctor, you have commented on the blood film. The red cells are like this, white cells are like this, platelet are like this. I will ask you, what is this? What is the impression? What do you think is going on? So you will tell me on the phone that this is the impression like that. Why not to write it in the blood film? That's how we were told that this is impression is a part of the blood film reporting. Then you need to tell you need to write your suggestions in the blood film that what should we do next. Okay, this is acute leukemia. So what next? So you need to write in the suggestion part of the reporting, and this patient needs urgent review by the hematology team in bracket right, which is myself, which is me. I'm the hematology registrar or consultant. I will review this patient urgently because this is hematology emergency. Okay, and I will submit his sample to HMDS for female RARA stain, and I will start airflying this patient urgently. You have given all the information in your report. No one can fail you in this case. Certainly, you will get 9 out of 10 marks. This is another case. The first candidate has written, the red cell shows mild and isopocylocytosis. Platelet counts are reduced, no clumps. There are multiple atypical white cells that are suspicious of lung. Impression is acute leukemia. Urgent flow cytometry on peripheral blood is advised. Bone marrow biopsy for confirmation. The second candidate has mentioned the blood film contains multiple blasts, some of which contain granules. Red cells show mild and isopocylocytosis. Platelet counts are reduced, no clumps, impression, acute leukemia, urgent flow cytometry, admission under heme and BMAT for confirmation. So the impression, content of report, suggestion, both the candidate have written correctly, but examiner will be happy with the second candidate because the second candidate has commented on the abnormality first. He has seen blast in the blood film and he has mentioned the blood film first. The first candidate, he has mentioned blast as well, but he was more bothered about red cells first and platelets. Okay. So if I have anything abnormal in me, I would pick that first. I would not go to red cells and platelets, which are not concerning thing here. The concerning thing here is the blast, which is visible here. Comment on the blast first. This is the important thing to be mentioned first in the blood film. So that's how your judgment in the exam is made. They would say this candidate has better judgment. He's worried about this blood film because of the visible blast. The other candidate is more bothered about red cells and platelet, not about the uh, blast in the blood film. That's how uh, when when you are at borderline and they are discussing you in their meeting whether to pass you or fail you, these things come in front of them. Okay, he was least bothered about blast first. He mentioned red cells. I think his judgment is not up to the mark. They will not pass. There's another case. Um, the blood film contained multiple small to medium-sized white cells, lymphocytes with mature chromatin. Red cells are normal, platelets are normal. Impression is lymphoproliferative disease. Action is to send peripheral blood to HMDS for flow cytometry. Now the differential. First candidate has mentioned Burkitt lymphoma, DLBCL, mantle cell, CLL, and the second has mentioned CLL, follicular lymphoma, mantle cell lymphoma. Which of the candidate is better in writing differentials and why?
The second one,
Why do
because
you think He has mentioned CLL. The first one has mentioned CLL as well.
Yeah, because they're very different. One is high grade, one is low grade. The first candidate mixed both, and it's unlikely to be Burkitt's, isn't it? And DLBCL, because they're morphologically very different.
Yeah, so all these things that I have picked up here are from the mock exam candidate. I have not published any name here, so do not worry about the names. I have maintained confidentiality. Unfortunately, I have seen these things in this current mock exam. That's why I have brought it here. If you are dealing with CLL, which is mature lymphoproliferative disease, do not say Burkitt lymphoma, DLBCL, or blastoid mantle. They are high-grade diseases. Their morphology is completely different from what you see in the peripheral blood. If you think this is CLL, the differential would be other related lymphoproliferative disease, follicular lymphoma, small cell mantle cell lymphoma. Mantle cell lymphoma has 5 different types. So writing Burkitt lymphoma, DLBCL, it gives a very strange impression to the examiner that he is confusing low grade with high grade. So how he would practice in real life. So do not write differentials like Burkitt or blastoid mantle or DLBCL for low grade lymphomas, leukemias, etc. All these things are counted in the judgment section when they discuss your answers in their meeting. So these are a few screenshots from the current mock exam. This candidate, the first candidate, has attempted both the cases on the same sheet. As I mentioned to you, in the real exam, the sheets are broken here and distributed among different examiners to check your answer. Okay. So if I am the examiner number 1 and I have your case number 1 and you have written some part of another question here as well, so you have lost a big chunk of your answer. They will give you negative marks, no marks for that. You will not receive any marks from that. That's how when we come out from the exam and we are satisfied and happy that I have done very well, I have made all the diagnoses of short cases, but when the exam result appear, oh, I have failed 6 questions in short cases. I have failed 5 questions in transfusion. How come? These are the mistakes that we do. Part 2 exams, you are ST6, ST7 level. You know a lot of things. Okay? There is no question about your knowledge. It is about skills that you need to learn for this exam, unfortunately. So this question should be on different papers in morphology and transfusion in the short case in the coagulation paper. I mean, okay? So these are the 3 examples which I have checked in the mock and I have mentioned to them. New question, new sheet, please. Coagulation. Coagulation, you will have 8 questions. I have written here plus minus NICOS because there can be a NICOS question in both transfusion or coagulation, but it is possible that they may not give you a NICOS question in coagulation or in transfusion. You have 2 hours, 120 minutes, okay, 15 minutes for each question. Okay. Unfortunately, people carry the same habit of writing more in the initial questions, and then they are in a hurry for the remaining 4 questions, just like they do in the part 1 exam. So we have done a lot of practice in our group for this exam. Hopefully, this problem will not be an issue in this exam. You should have your watch, 15 minutes for each question. 15 minutes are done, move to another question. If you are stuck in one question and you spend 1 hour on that, or for example, sorry, half an hour on one question, you are left with little time for the remaining question, and you will be in a hurry. When you are in a hurry, you make mistakes and blunders that can affect your whole exam. Time management is a skill which comes with practice. Management mnemonic, it is still very, very relevant for part 2 exam as well. We have published that in the part 2 group multiple times. It is present at the end of this presentation. You need to write all the things of management that you were writing in part 1 exam. MDT is relevant in part 2. Consenting is relevant in part 2. Pregnancy testing is relevant in part 2. Cards are relevant in part 2. Follow-up is relevant in part 2. Prophylaxis is relevant in part 2. Family screening and bleeding disorder is relevant in part 2. If they ask you a management question, you have to write all these things. All these things carry a mark. If you do not write them, you will not get a mark. That's why we fail the questions or in coagulation or transfusion. We have made the diagnosis, it is a hit. But when they ask about the management, we have not mentioned hit card, hit antibody card, or flag in the PPM or in the EPR or our system, etc. They will deduct a mark from that. Then you think how we have failed the exam. And unfortunately, they do not give you a detailed feedback. They just write irrelevant details, insufficient details, poor handwriting, etc. Plans. We have practiced multiple plans in our practice sessions. I have given you my hospital plans as well for different hemostasis conditions, and they were present in the mock exam as well. And hopefully you will have enough practice. But question is must in the exam about the plans. Either it will be a perioperative plans. Yes, they are perioperative plan on the dabigatran, warfarin, duox, heparin, etc. And the situations will be different. The patient would have a DVT a week ago, or maybe 3 months ago, etc. Reversals, pregnancy contraindications, principle of common hemostasis investigation, they are common. The LTA especially is common both for VIVA and the paper. DRVVT common for VIVA and paper. These are the few examples. And if you are carrying coagulation bleed in your daily life, you should be able to answer all of these questions. But answering these questions needs a skill that we have practiced already. Some examples from our mock, and I have not included any name here because the attendees are present in this session. They would recognize their handwriting. This was a TTP question. First of all, these pyramids are here. I do not know as an examiner what is meant by pyramid, these pyramids. Okay, that's why I mentioned what is this, and the candidate carried a negative mark for that. The question was, what is the most likely differential diagnosis? And the candidate has mentioned here TTP, HUS, preeclampsia, atypical HUS. So these all comes under irrelevant details and a negative mark. You will carry a negative mark for that. And the candidate carried a negative mark. The candidate scored 12 marks, and the 13 mark was the passing mark for that person. Then I was expecting that this candidate would write the first sentence here as, this case is most likely a TTP, which would need a discussion with TTP consultant to agree upon diagnosis. After that, I would say, I would assess the patient, I would speak to the patient, I will see blood films, blah, 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 whatever the candidate has written. But if I have identified that this is heme emergency, and this is a TTP, my first sentence should be, because in the scenario, they had given you enough information, all the blood tests, the blood film, and you pick that up from the scenario that this is TTP. they ask you what is the immediate management of this patient. Okay. This patient is most likely having TTP, which is heme emergency. I will discuss it with the TTP consultant to agree upon diagnosis. This is what the algorithm of TTP says. If your patient has blur vision and he has a background of Waldenstrom as well, you would say it's most likely the patient has developed hyperviscosity system symptoms, which means heme emergency, and you need to arrange a plasma exchange urgently for the patient to reduce his viscosity. Again, same statement for the APML as well that we discussed. So this candidate has mentioned for the TTP. First of all, um, try upon your handwriting so that the examiner can read it. Yes, I have read everything in this answer, but if it can be more better than this during the exam, it will be okay for the examiner to check your answer. So the immediate management for this patient, yes, you have sent items TS13, ITU, but there are some other aspects of management as well. What about prednisolone? What about folic acid? What about pregnancy testing? What about discussion with the patient? They're not asking about treatment. They're asking about immediate management. There is a difference between immediate management and immediate treatment. And if you are working in TTP center, as I mentioned with my mock candidate, if you are working in TTP center, write in a bracket, my hospital is a TTP center, so that they know that your answer will be a little bit different from the other candidate. You need to write all the aspects of management. When we have a TTP patient, we do not stick a needle in the patient to do the plasma exchange. We tell them that I have discussed with the TTP consultant, and I have seen your blood film, and we think that you have a TTP which has high mortality. If
High mortality. If
there is some background noise, uh, if you do not intervene urgently, do the pregnancy test. If the patient is a young female, give the patient folic acid, some prednisolone, discuss about plasma. Maybe the patient is Jehovah Witness. If you mention consenting, patient may be Jehovah Witness. Inform your ITU, anesthesia. These are all the aspect of management that we do in practical life. But in exam, yes, we are in a hurry and there is anxiety. We forget these things, and you lose marks when you do not write in the exam. Why I have included this picture here? Because this answer tells me that this candidate is not aware of the updates in hematology. They would expect you that you know everything that is recently published in the noise or in the BSI. You have a new update 2 days ago on 24th about multiple myeloma. Okay. Initially, we had belantamab as second line. Now we have another regimen as second line as well. So this candidate has mentioned 4 weeks anticoagulation because the patient has proximal DVT. Now the things has changed. We give them 12 weeks DVT, 12 weeks anticoagulation. So if you don't know about the updates, then how you will get marks? You will write the things wrong. The answer key that is present with the examiner will mention different things. Then this candidate has mentioned question number 3, 4, 5 all together. Please don't do this in the exam. Okay, you have to appear again in the exam if you do not get. You have to answer question number 3 separately, question number 4 separately, question number 5 separately. Even if they are same questions, still you have to say question number 3, separate answer, 4, separate answer, 5, separate answer. Cancer-associated thrombosis, if you give warfarin to them as a first line, for sure you will come to the exam again. That's why I have written here suicide. And luminal cancers, if you have not resected them, why are you giving them drug? If you have resected the tumor, luminal tumor, yes, then depending upon the site of absorption, you can decide any drug for them. But if you have not resected them, the guidelines tell you that there is a high risk of bleeding in them. Do not give them drugs if the luminal cancers are not resected. If the patient has cancer-associated thrombosis, do not give them warfarin as first. Warfarin is the least considered choice in the cancer-associated thrombosis. These are considered as blunders, and you cannot pass exam if you make blunder. Transfusion, it's the lengthiest paper in the exam because you have to write a lot. There are clinical scenarios, there are managerial scenarios. They may ask you that the patient has received irradiated blood, manage this scenario as a transfusion consultant. There is a long blood in tube, manage this case as a transfusion consultant. Shortage of platelet in your hospital, manage this case as a transfusion consultant. You would have practiced these cases during your transfusion courses and with us as well. Principle, KH principle, sorry, the FMH principles are important in transfusion, or DAT testing, or elution, or adsorption, they would ask. When you enter the room of transfusion paper, keep in your mind, sure, you have to refer every case in transfusion to short, unless you have recognized that this case is not short reportable. If you go to the transfusion paper room with this mind, you will not miss anything. You will not miss short. If you miss short in the exam and the case was short reportable, they will shoot you. Means you have made a big blunder, which is not expected at the consultant level. And management mnemonic is still applicable in this case as well, in transfusion as well. This is a nice picture of a lady with a pistol. Hopefully this picture will remind you during the exam that you have to refer transfusion cases to short, unless they are not short reported. Again, few screenshots from the mock exam. The candidate has answered everything about hyperhemolysis. He has treated the hyperhemolysis very well. Everything that is mentioned in the guideline for hyperhemolysis treatment is mentioned in this answer, but he has not reported the case to short. So if you have not reported the transfusion reaction to the short, how can I give you passing marks in the exam? That's how we fail the exam unexpectedly. Yes, we have identified this is hyperhemolysis, but we have not written all the stuff that is required. And the required stuff was the lifeline of the answer, which is short. I have written here as short reportable. It is short, SHOT. I have written the spelling wrong. Again, this was a NATE question. The question was, what is the management of subsequent pregnancy? Candidate mentioned directly IVIG since week this, MDT approach, etc. You need to mention something about management that you have to explain to the patient about NATE, its risk associated with the pregnancy, whether this is the same partner or different partner, It will be under MDT in a comprehensive care center. What are the options that we can offer you? What we will do after starting IVIG? How we will monitor the response to IVIG? What is fetal blood sampling? How we do that under cover of IUT platelet, etc. Then you will get some marks. If the question is immediate, what is the subsequent management? What is the management of subsequent pregnancy? You just mentioned IVIG from 12-week, IVIG from 20th week. If no response, increase the IVIG dose or add steroid. This is treatment section. This is intervention section. If I am a female and I have a NATE in a previous pregnancy and I come to you and discuss about the pregnancy, you will not tell me, okay, get IVIG. You need to tell me what is the risk, how you will manage the case, who will be involved in this management, what you will do, what is IVIG. I don't know what is IVIG. So please differentiate between treatment and management in the exam so that you can get some marks. Then this was about TAGVHD, transfusion-associated graft versus host disease. Why I have included this question, this answer here, the screenshot here, because the candidate says that explain to the patient that it's fatal. So the candidate has wrongly picked up that this patient has TAGVHD. This patient has not TAGVHD. There is a risk of development of TAGVHD, of giving non-radiated blood to a patient where radiated blood is required. If you give a wrong information to the patient and saying it's fatal as well, yes, TAGVHD is fatal disease, but it is not yet developed. The risk is very low. All blood product in the UK is lipid depleted. Giving wrong information in the exam is fatal for you, not for the patient. For you, it is fatal. So this highlight that you need to read the question carefully. What are they asking you? Patient has received non-radiated blood. You are asked to manage this as a transfusion consultant. You have reviewed the patient. You have mentioned that there is a risk of developing TAGVHD. What is TAGVHD? Give them leaflet and tell them why the risk is low. Because all the blood products are leaflet. Again, this was a question where the patient should be referred to short. I have circled this thing here. The candidate has mentioned SHT. I do not understand what is meant by SHT. Is it short? Is it special hemoglobinopathy center or something else? I have not picked that up. Okay, so I have question mark it. And this in this answer does not contain short reporting. Patient received 0 mark and failed this question. Everything is correct. There is no short report for hyperhemolysis here. Again, if you are attempting transfusion scenario, please, new question, new sheet. Otherwise, you will lose marks. Day 3 is a viable. 2 stations, each station cover 2 subspecialties. Transfusion and coagulation are together, and then oncology and general hematology consultants are sitting together as well. They ask you 4 questions, 2 questions from each specialty, 2 coagulation, 2 transfusion, 2 general, 2 oncology. Each question is for 7 minutes. Why is standard? It's not that I am the candidate, first candidate in the morning, I will have different scenario, and the last candidate at 3 p.m. will have a different scenario. No, same scenario throughout the day. Sober dressing, consultant-like dressing, better, look fresh, smile. You would have practiced a lot. You have seen a lot of patients. You are ST6, ST7. You have a lot of hematology experience. These things they will ask you in the exam as well. It's better to keep eye contact. Opening question does not carry any mark. Okay. And the answer should be qualitative. If your opening question is what is the differential diagnosis of high platelet count, and you start talking, there are hematological causes, non-hematological causes. Hematological causes are this one, non-hematological causes. You mentioned 15 causes. They will only look at you like this. When you stop, then they will start their next question. Okay, they will not tell you, okay, stop here. We will ask another question. No, when you stop, they will ask another. If you don't know the answer, say, I do not know the answer. Please, next question. Do not say anything irrelevant. Do not make answer from yourself. You may make a big blunder that may affect your whole exam. And when they tell you that the patient has come to ED, 82-year-old female has come to ED with bruising all over the body, say, I will examine my patient. This is now your patient. This patient has a bleeding disorder, likely acquired bleeding disorder. Say, I will examine my patient and explain that most likely we are dealing with acquired bleeding disorder. We need to give you some um, medication to stop the bleeding. When you say my patient, the examiners are happy that you are owning your patient. And this is just an extension of your real day practice by another day in the exam. In the management mnemonic, you need to keep in your mind. Okay, if they ask you how will you manage a bleeding disorder patient or platelet disorder, for example, okay, you are giving this patient tranexamic acid to home when the patient is at home. But also you need to register the patient with the tertiary center, bleeding disorder count, a school plan, etc. Offer family screening, genetic testing, counseling, etc. These all comes a part of your management of the patient. Is there any significant thing about these scenarios? Anyone can point out why these scenarios, what these scenarios are mentioning here? What is important about it?
Females.
So they're all
Young
childbearing age.
Starting
Sorry.
as female.
When they give you a question in the exam, if it is a morphology case, if it is a transfusion or coagulation case or viva case, and they tell you that this is a female patient and the female patient is of childbearing age potential, they expect you to say pregnancy test, or if you do not mention, they will tell you, okay, the patient is pregnant. Then you feel a bit embarrassed. I should have done pregnancy test. So yes, in the female patient here, in the real practice, the nursing staff do pregnancy test before any intervention. They do the pregnancy test, and they tell us whether it is positive or not. If it is negative, nobody tell us. But if it is positive, nursing staff tell us we have done the pregnancy test in this female. It is positive. So if in general case, usually they ask you about essential thrombocythemia or autoimmune hemolytic anemia associated with any LPD. It will be a young female. You need to mention that after a negative pregnancy test, I will give this patient hydroxycarbamide, for example, to ET patient. But if you do not mention, they will ask you, would you like to do any other test in this patient before deciding chemotherapy? And if they give you this prompt, you lose already 1 mark. Prompting carries negative mark in part 2 exam, which means you are missing something important. Be careful about that. This is the management mnemonic that I was talking about. Okay, breaking bad news, beliefs, MDT, these things are still important in your part 2 exams as well, during the management of your patient. The success in FRCPath exam needs both expertise and smart exam techniques. Many brilliant candidates fail the exam multiple times because they do not know about the exam skills. Many people clear the exams during ST5 because they know the exam techniques. That's the difference. So this was the last slide. If you have any questions, please, we have only 10 minutes. Anything you would like to ask?
Assalamu alaikum, sir.
Yes, no, it's not.